थोड़ी सी हमारी प्लानिंग में ऊंच नीच हो गई, जिसकी वजह से स्किल सेशंस की बजाय हम केस प्रेजेंटेशन पे जा रहे हैं. Skill sessions most probably we'll be having next Wednesday, and we will try to arrange it in a manner that the main exhibits of the skills stations, one or two, they are projected on the screen or on your screens adequately for you to get a grasp of those skills which are being demonstrated or which are being explained, along with, of course, the audio. Today's presentation is about a case of subfertility, as Dr. Sana, who's going to present, has labeled it. And just before we started this conversation, I asked her, why is it called subfertility and why not infertility? And this is a question to all of you. You might want to respond to that. You can write your responses over here. But let's begin with Dr. Sana's case presentation.
Assalamu alaikum everyone. My patient Mrs. Kawal Farhan. Mrs. Kawal Farhan, wife of Mr. Farhan Akhtar. She is 30 years of age, is a resident of Faisalabad, is a housewife with no formal education. She has been married for 12 years. Her blood group is O positive. She is nulliparous. Her last menstrual period was on the 7th of March 2021. She was admitted to the Hamidlatif Hospital on the 15th of March 2021 via outpatient department with a complaint of inability to conceive for 12 years. The couple has been married for 12 years. It is their first marriage. They have been living together since marriage. Their coitus is satisfactory with a coital frequency of 2 to 3 times a week, and there is no dyspareunia, postcoital pain, or postcoital bleeding. Her menstrual cycle has been regular with 6 by 28 day cycle with average flow and mild dysmenorrhea. But there was no intermenstrual bleeding. There is no history of weight gain, hirsutism, acne, no history of any heat or cold intolerance, no history of galactorrhea, or any significant vaginal discharge. She has had history of pulmonary tuberculosis in 2015, for which she took treatment for 9 months. But now she has no history of cough, fever, or weight loss. Her tubal patency was checked via hysteroscopy in August 2013, on which she was told that her right fallopian tube was blocked. However, the left was patent, which she does not have any report with her.
When was this?
So this was in August 2013. She did not have any specific blood tests done previously. Her husband is 33 years of age, is a shopkeeper, non-smoker, non-addict, and has had no previous medical or surgical history. His semen analysis was done 1 year ago, which according to the patient was normal. The patient has taken multiple cycles of ovulation induction. However, she never had any scan in the 12th day for follicular tracking. Now, the patient is presented to Hamidlatif Hospital in outdoor for further evaluation and management. In her medical history, she has had pulmonary tuberculosis in 2015, for which she took treatment for 9 months. Other than that, she has no history of diabetes, hypertension, any heart issues. In her previous surgical history, she has had an open appendectomy in 2006 at Faisalabad. In her family history, there is no history of subfertility in the family, no history of diabetes, hypertension, asthma, tuberculosis, or ischemic heart disease. She is not allergic to any medicines, or there are no food allergies as well. Her age of menarche. Her age of menarche was 13 years. She has had regular menstrual cycle. with her menstrual cycle of 6 by 28 days with average flow and with mild dysmenorrhea. There is no history of intermenstrual bleeding. She has never practiced contraception and pap smear was not done. Her last menstrual period was on the 7th of March 2021. Her husband is a shopkeeper who earns around 30,000 per month and they live in their own house and basic necessities of life are met with difficulty. Should I move on to the examination?
G.
A young lady sitting
Voice not clear the mark. उधर पॉलिकल बैठ जाओ ये कुर्सी पे बैठ जाओ और मास्क उतार लो
She's a young lady sitting comfortably, well oriented in time, place, and person. Her height is 5 feet 4 inches and her weight is 60 kilograms, making her body mass index to be 23 kilograms per meter square. Her blood pressure was 120 by 80 millimeters of mercury, pulse 82 beats per minute. Temperature was 98 degrees Fahrenheit. There was no pallor, jaundice, clubbing, polyonychia, or leukonychia. Her thyroid and accessible lymph nodes were not enlarged. Accessible lymph nodes were not enlarged. In a cardiovascular examination, the first and second heart sound is audible with no added sounds. Yeah. Voice separation.
Loud and clear. Take it first.
Her first and second heart sound is audible with no added sound. There's normal vesicular breathing with no added sounds. On breast examination, on inspection, the breasts are bilaterally symmetrical with normal nipple and areola complex. On palpation, there was no lump palpable in any quadrant and there was no nipple discharge. On abdominal examination, the abdomen is flat with central umbilicus, moving symmetrically with respiration. There is a visible appendectomy scar in the right iliac fossa. There are no visible pulsations. On palpation, the abdomen is soft and there is no visceromegaly. No mass palpable. On pelvic examination, the external genitalia on inspection, the vulva is normal looking with normal hair distribution. On speculum examination, all visible vaginal walls are normal looking. The cervix is nulliparous and there was no discharge seen. On bimanual examination, the uterus is normal size, anteverted, mobile, non-tender, the fornices are clear. There was no discharge or bleeding on the finger at the end of examination.
Summarize your case.
Mrs. Kawal Farhan, 30 years of age, married for 12 years, wife of Mrs. Farhan Akhtar. She is a housewife with no formal education and nulliparous, presented to the OPD of Hommeopathy Hospital on the 15th of March with a complaint of inability to conceive for 12 years. Her last menstrual period was on the 7th of March 2021. It is the first marriage of the couple with, they have been living together since marriage. Fertility frequency was normal. Her periods have been regular with a cycle of 6 by 28 days. With no history of any weight gain, hirsutism, acne, galactorrhea, heat or cold intolerance. And she has had pulmonary TB in 2015, for which she took medical treatment for 9 months. She has had a hysteroscopy done in 2013, in which she was told that her right fallopian tube was blocked, but the left was patent. She has not had any blood tests done, but her or TBS. But her husband Semen Analysis was done, which was normal. But the report was not available to the patient.
This is not a summary. Summary is 3 or 4 sentences or 5 sentences. Summary would be 30 years, married for 12 years, living together, no conception. History of pulmonary tuberculosis, treatment for 9 months. Hysteroscopy and 2013, one tube block, one patent. Husband semen analysis, no. Full stop. You see, those are the essential facts of the case that is to be given, which will depend. What do I have? बाकी सारी चीजें कि उसमें ये intercourse, blah blah blah, सारी चीजें उससे निकल जाती. Until then, unless या अगर ये वो उसमें कि जी marriage consummate नहीं हुई, there is sexual problem because of which there is fertile frequency के ऊपर है, whatever. Until and unless that is there, वो mention करने की जरूरत नहीं, वो भी ठीक हो.
And I think that one of the lessons from this history is that it is very important to know how to summarize your case. अगर आपको केस समराइज नहीं करना आता तो आपका पहला स्टेप क्या होता है? Soon as you finish the history and narrating the history and examination, inadvertently every time the examiner will ask you to summarize. तो summarize करना आना सबके लिए बहुत जरूरी है. और जिस तरह से सर ने कहा है, summary basically means salient positive features and salient negative features in history and examination.
Otherwise, तुम्हारी history, examination और description वो ठीक थी. तुम्हारी जो speed और आवाज और वो है, वो भी ठीक थी.
मैं जिस point of view इसके लिए important है, आपकी patient है, उसको 12 साल की infertility. ये नहीं हो सकता कि 12 साल में कुछ ना हुआ. कुछ तो हुआ है, मैंने बताया. The important thing is that I would have thought that you should have brought the semen analysis up pretty quickly. You did, but as a last thing. Semen analysis सबसे ज़्यादा important है इसके अंदर. Especially जब आपने हिस्टो पहले बता दी और आपने कहा कि एक ट्यूब ब्लॉक है. My next question is the semen okay or not? And then you cannot say that the semen is normal if you haven't seen the report. ठीक है? So तुम कहोगे कि according to the patient, the analysis is normal, but I no report.
The voice not clear, right?
मैं कह रहा हूँ कि वो
नहीं वो
इंटरनेट का इशू
वो है
मेरे तो वैक्सीनेशन सर वो ये तो इंटरनेट का किसी का इशू
वो है कह रहे नहीं मतलब ठीक है चलिए कुछ ना कुछ करें दो तीन लोगों को आवाज नहीं आ रही थी.
So important चीज ये है number 1 कि summarize करना आना चाहिए. Number 2, in the case of infertility for 12 years, the history of treatment of infertility, investigation and treatment of infertility, जैसे कि ovulation induction हुई कि नहीं हुई, क्या हुआ,
और multiple cycles.
So उस किस्म की चीजें जो है
वो समरी में आप बता सकते हैं. समरी में ये जिस तरह से उन्होंने कहा कि ट्रीटमेंट की हिस्ट्री समरी में semen analysis claims normal, tubal test, many times ovulation induction, right? वो हो गई. Tracking or no tracking, that does not really mean वो इसमें relevant नहीं बनती, but ovulation induction. But your as I said earlier, your history is good. Your exam वो सारा कुछ complete. अब इसको what for practice sake you will write its summary और वो 2-3 दफा उसमें से देखो कि कौन सी चीजें जिसको strike out कर सकते हो. So उसको minimum but not omitting any vital information, negative or positive. वो करके करेंगे. चलिए जी अब पहले तो आपसे हम 10 मिनट पूछेंगे फिर बाकियों की राय लेते हैं. Madam's tips are very nice but voice not clear. मैडम आप अपनी वॉइस क्लियर करें जरा.
सर आपको भी कह रहे हैं मास्क रिमूव कर दें.
अच्छा चलो मैं मास्क
नजर आ गई. कहां जाऊं हां वैसा था जो सर
जी मैम.
maybe just one time.
अच्छा जी अब आप बताइए कि हाउ विल यू मैनेज दिस पेशेंट.
एक मिनट मैं फर्स्ट टास्क कर लूं वैसा का मैनेजमेंट से.
हां चलो.
Okay. So what do you think is the probable cause of infertility in this patient?
Her tubal factor is a bit her tube is blocked.
So you think that
the cause is she has had pulmonary TB, so she might
TB mat or tuberculosis.
She has had tuberculosis, so that could be a cause of her pelvic inflammatory disease and resulting in tubal blockage.
How does tuberculosis cause infertility? तो मुश्किल नहीं पूछा. तो सब ओके मैं जवाब दे देती हूँ. तुम्हें नहीं आता. Tuberculosis infertility तब करेगा जब pelvic tuberculosis होगा. So if there is pelvic tuberculosis, only then there will be infertility. And in pelvic tuberculosis, the fallopian tubes are affected. There is endosalpingitis, and that endosalpingitis actually results in the tubal blockage. Right? Okay. So, what investigations do you want to do in your patient?
So I would want her complete blood count, in which I want to see her hemoglobin. Apart from that, I want her hepatitis B surface antigen. And
apart from that, is superfluous.
Would you like to tell me what specific investigations you want to do to find out the cause of infertility?
Yes. Her follicle stimulating hormone levels, her luteinizing hormone levels, thyroid stimulating hormone levels, serum prolactin level, and a pelvic scan.
What is the objective of the pelvic scan?
Basically, to see the size on the 12th day, a transvaginal scan preferably, to see the size of the follicles, and also to see if there's any uterine adnexal pathology.
Okay.
And also her husband's semen analysis.
What is the WHO criteria of semen?
I know. Okay, so the WHO criteria for semen analysis that the count should be more than the total more than 39 million per ejaculate. The sperm concentration should be more than 15 million per ml. The morphology should be 4%, and the motility, the total motility should be 40%, in which the rapid progression.
Lower limits up.
हाँ जी, मतलब bare minimum इतना से ऊपर.
Lower limits यहाँ.
Lower limits, yeah. The total motility should be in which the non-progressive and the rapidly progressive are both included is 40%, and the rapidly progressive should be 32%. Or
32%.
Yeah, 32.
Okay, so what do you think is the cause of infertility in this patient, and what investigations do you think you need other than what you have said? Do you think you need some other investigations?
Yes, I also want because I want to plan her diagnostic laparoscopy. So I want hepatitis B surface antigen, anti-HCV, anti-HIV, all of that.
You only want to do a diagnostic laparoscopy when you know that one of the tubes is blocked, or would you like to do proceed?
Yes,
operative.
I like to proceed as well, which was actually done.
Yeah. Yes. Okay. What are the 3 most common causes of infertility?
2 most common causes of infertility are maternal, like the
causes in the female and
causes in the female and the male, and which could be hormonal causes in the female. And
which are the most difficult to define? tubal बोलो लड़की जो तुम्हारे पास patient
So basically tubal blockage है, endometriosis है, PCO है, और चौथा जो है वो semen parameters है जिसमें problem. ठीक है. So how will you counsel this patient? Yes, sir. के पास जाए.
So first of all, I will talk to the patient, counsel her regarding the fact that she has been married for 12 years and that she has taken multiple cycles of ovulation induction previously. Also on her hysteroscopy, one of the tubes is blocked, the right tube. So I will tell her that.
When was that done?
August 2013.
So it's too old to be counseling on that report. It's 8 years ago. This hysteroscopy was done 8 years ago.
But so I will plan her diagnostic laparoscopy for confirmation of tubal patency, for any uterine adnexal pathology, and then I will discuss, according to the diagnostic laparoscopy, I will discuss the treatment options with her, which could be ovulation induction.
Treatment options are good. Sir?
Depending on the diagnostic laparoscopy findings.
All right, on the diagnostic laparoscopy, first I'll get back to your.
Also,
you said that you will do pelvic scan. Why do you want to have pelvic scan?
To see the size of the follicles. Follicular size.
Which means that you think that she's been menstruating for the last 17 years without ovulation. She has a regular menstrual cycle. So what are the tests for tubal ovulation? How do you determine whether a woman is ovulating or not?
So okay. So for that, we go for the follicle stimulating hormone level test. And ovulation.
First, you talk to the patient, talk to the woman.
And we ask about the menstrual cycle.
Menstrual cycle.
Menstrual cycle.
If she has a regular menstrual cycle, mostly 80% of the time she is ovulating.
Yes.
Because an ovulatory cycles for the last 17 years since her menarche to the age of 30 is extremely unlikely. And she has had ovulation induction quite a few times. But anyway, so you have for assessment of ovulation. I'll grant you that, but You should know that.
The menstrual.
That all, and the answer should be that although she has a regular menstrual cycle, but still I would want to know the status of ovulation and status of the ovaries, antral count, etc., etc. You can say that.
I think इस ventral follicular count कहना बनता था, because multiple time ovulation is also मतलब one of the factors.
अच्छा, all right. और pelvic scan पे आप क्या देखना चाहोगे?
Sir, any the size of the uterus, any uterine or nexal pathology?
What kind of any color was been important?
Okay.
What kind of adnexal pathology would you want to see after you have examined the patient? You have carried out bimanual examination. You did not feel any adnexal mass. So, what kind of pathology do you expect?
The polycystic ovarian, like in more polycystic ovarian syndrome, if there's any.
Is she a phenotype polycystic ovaries? चले हो गया. अब आ जाओ उसकी तरफ. आप कर रहे हो लैप्रोस्कोपी. लैप्रोस्कोपी पे ट्यूब पेटेंट है वो राइट वाली लेफ्ट वाली. Then what would be your next management?
Okay, so again, I will counsel the patient that one of her tube is blocked, but the left one is patent.
That is known. That is the known fact for
so
the last 8 years.
I will go for try insemination because she's.
I will not.
You will not. You will still go.
I will not. I will not even do her laparoscopy. I wouldn't.
12 years, multiple ovulation options.
I wouldn't.
You would go for direct IVF?
I would go direct for. I would go direct for IVF.
She's very non-affording. She is.
It is irrespective. Irrespective of that, affording wali baat. अब मुझे ये बताओ कि what happens to the tubes when there is tuberculosis of the pelvis?
Endosalpingitis.
What is endosalpingitis? What happens in endosalpingitis? Is pelvic tuberculosis primary or secondary usually? Secondary to what primary sites? कहाँ पे होती है primary?
Lungs.
Lungs में और
Intestinal
और
abdomen होती है और tuberculosis and meningitis भी.
Common जो होती है lungs, lymph nodes, abdominal, bones, but it usually is secondary pelvic tuberculosis. And when it affects, what is the effect on the tubes? There may be biosalpinx. The tubes may apparently look normal. They may look inflamed and thickened and little larger.
Beaded appearance.
Beaded appearance is on a hysterosalpingogram graph, and they may even be patent. But you can't really have plastic patent tubes implanted into the uterus because those tubes will not propel the ovum towards the uterus. So, patent tube in a case of pulmonary tuberculosis with history of 8 years infertility, one tube blocked, which means the tube has been affected, is very unlikely to be, very unlikely to be able to facilitate the passage of ovum. So, therefore, that kind of background knowledge about the effect of tuberculosis on tubal patency is essential. You see, it's important that in this patient, that tubal test was done. Now, if she has, there is this patient and she is still taking anti-tubercular treatment for her pulmonary tuberculosis, and she presents with infertility, would you do her hysterosalpingography or laparoscopy or not?
We'll first complete her treatment.
जब कैंडिडेट की आवाज गायब हो जाती है ना तो इसका मतलब होता है कि जवाब नहीं आता.
लेकिन
say it out aloud.
लेकिन वो बात ये है तुम्हारी कि वो उस लिहाज से why wouldn't you not do it that time and why would you wait for the treatment to be completed? ये मैं इसलिए पूछ रहा हूँ कि if you do it at that time, then there can be a flare-up of the pelvic tuberculosis. If you do a tubal patency test while she is still under treatment of tuberculosis, she is taking medical treatment, ये हो सकता है.
इसमें और point भी है. So you said that you don't need a diagnostic laparoscopy because you already know that she has got pelvic tuberculosis and one of the tubes is affected.
But that we can disagree on that. And
No,
ultimately, I will agree to what you say.
मुझे पता है मैं वही आना चाह रही थी कि मैं ये कहना चाह रही थी कि one of the objectives of doing the laparoscopy also is to strip the tubes because if there is hydrosalpinx or if the other tube is patent, then you will just be promoting an ectopic pregnancy in this idea. So laparoscopy की जरूरत तो
पड़ेगी. Laparoscopy plus clipping of the
and proceed में मतलब detail exactly. Initialization
वो देखो वो साथ में वो लिखा है no salpingogram because it aggravates the disease. नीचे क्या लिखा है no gap it flare up disease.
So basically बात ये है कि अगर आपने क्लिपिंग भी करनी है, ट्यूब पेटेंट भी है, तो लेप्रोस्कोपी तो आपको कहीं ना कहीं उसमें करनी पड़ेगी. इंजिशलाइसिस पेशेंट की पेन को कम कर सकता है, फर्टिलिटी को हेल्प नहीं करेगा. अगर पेशेंट को
इसके लिए राइट सेल्फ इंजेक्टरी
क्या किया,
राइट सेल्फ इंजेक्टरी और
लेफ्ट ट्यूब को क्या,
दोनों तरफ जो थी ना थी हाइड्रोसाल्पिंक्स राइट हेमाटोसाल्पिंक्स का राइट को क्लिप किया और
ये वाली
और इसकी इतनी ज्यादा रीजंस थी, पूरा प्लास्टर था एब्डोमेन, तो रीजनलाइसिस के एक्सटेंशन.
अब ये आराम से डिटेल फाइंडिंग बताओ क्या हुआ.
ठीक है सर, नहीं वॉश अप सर.
सो व्हाट वाज द फाइंडिंग्स ऑन लेप्रोस्कोपी?
जो याद है तुम्हें बोल दो ना.
मैं तो बोल रही थी.
हां सर मुझे याद है. अच्छा मैंने लिखा हुआ था. एक सेकंड मेरे पास. एक सेकंड
कि कैंडिडेट गुटियां ढूंढते तो मैं सवाल पूछ लेती थी.
नहीं मुझे पता चल गया, मैं बताती हूँ. Okay, so her basically she was planned for diagnostic laparoscopy and proceed, in which her with the help of 110 mm to 5 mm ports, we observed that her mentum was plastered to the anterior abdominal wall. Adhesiolysis was done. There were bilateral tubo-ovarian masses which were adherent in the ovarian foci. Left ovary was not present, and
not visualized.
No, it was not present.
Was it removed?
Just as she has only had history of appendectomy, इसके अलावा she did not give any surgery.
बात यह है कि was there evidence of removal of the ovary?
सवाल आ गया सर आपकी.
The question sir fertile patients.
ओ पहले आ गया.
अच्छा जी. Okay, so basically
was there evidence of removal of the tube?
Like there was no. Yes.
Did you visualize
no.
the ovarian ligament?
Yes.
Ovarian ligament कहाँ पे खत्म होता था?
उसके आगे कुछ भी नहीं था.
नहीं वो plastered था ना.
हाँ.
Plastered होगा तो the ovary may be behind that.
नहीं थी. Left ovary was not. Then even the right was smaller in size.
So is there any history of surgery?
Yes, she has an appendectomy done.
Appendectomy है तो left tube नहीं थी.
Left
ovary जो है. Anyway, let's not go into that. वो तो हो गया.
ठीक. इसके अलावा सर की ना right hematosalpinx था. Right salpingectomy was done after counseling the patient's attendants. There were also perihepatic adhesions. Fitzhugh-Curtis syndrome.
वो किस में होता है? Perihepatic adhesions ये जो तुम बोल रहे हो. PID कौन सी PID? Chlamydia में होता है. वो chlamydia वाला adhesion होते हैं. वो ठीक है, वो irrelevant है. इसमें tuberculosis वाली है. Tuberculosis तक रखो अपने आप को.
ठीक है. तो हमने तो राइट salpingectomy.
चलो तुम लोगों ने salpingectomy कर दी तो अब क्या करना है? मुझे तो तुम बड़ा एकदम से कर रही थी कि अच्छा IVF कर.
ये देखिए जितने आपके कैंडिडेट थे सबको पता था कि
chlamydia. हाँ.
Good answer, candidate.
Sir, a question: Subfertile patient with scanty periods and cyst. Do we go for laparoscopy? Yes, laparoscopy is more than scanty periods and cyst because it gives you a good assessment of the uterus, the appendages, the status of the ovaries, the tubo-ovarian relationship, the direct visualization of the femoral end and the tubes as well. Not that it always is correct, because I remember a patient in whom I wrote, the tubes were patent, but the tubes were so convoluted that I wrote in my notes that she most likely will not become pregnant, and the next month she came with a positive pregnancy test. So that is what can happen. But still, laparoscopy gives you the best opportunity of assessment of the reproductive system, female reproductive system, in that how do you proceed with that?
I think there's another point. Because the question is that in a subfertile patient with scanty period and a cyst, if you're talking about cyst, you mean polycystic ovaries and scanty periods, that may not in itself be an indication for laparoscopy. So if it is infertility, because scanty period is not an indication for laparoscopy.
I think scanty period, नहीं subfertility है ना, subfertility
So
है.
subfertility in itself is
वो है, but अगर ये वाली बात है, आजकल अब gradually, you know, in addition to laparoscopy, hysteroscopy also has become a part of the workup of infertility like that, and particularly in a woman who has scanty periods, it is good to assess her endometrial cavity by hysteroscopy. So opportunity should be taken to do that. And I'll take this point. I don't do myself. I don't do hysteroscopies, but I will urge all of you who are becoming gynecologists, not infertility specialists, who are becoming general gynecologists, that you must familiarize yourself with hysteroscopy. Hysteroscopy is now becoming an OPD procedure because of finer instruments, because of the fact that you can perform it without an anesthesia, and there is a lot to be said about outpatient hysteroscopy. So it's in evaluation of infertility patients, evaluation of patients who have abnormal uterine bleeding, and those in whom, say, the ultrasound shows that there may be a polyp or something like that. So evaluation of infertility, abnormal uterine bleeding, whether it is excessive or it is on the scantier side, hysteroscopy is an important tool in the armamentarium of a gynecologist. And therefore, I urge all of you to familiarize yourself and become expert in that and start doing it in your OPDs. I'm sure the equipment, and if you go into private practice, then you should buy one of your own, and you can do it, and it is now called office hysteroscopy. The equipment shouldn't be very, very expensive, so you can do it. All right, sir.
So can I get a cyst? It was a 5 centimeter cyst with lower.
5 centimeter cyst is something which you can ignore. It can, in all probability, I'll treat it as a functional cyst, depending upon its characteristics on ultrasound. What does it look like? Does it appear to contain blood, or does it appear to be an endometriotic cyst or hemorrhagic cyst? If it's a hemorrhagic cyst, it can be a luteal cyst, corpus luteum cyst, or it can be an endometriotic cyst. In either case, it should be observed for a couple of months, because most of these hemorrhagic small cysts, they resolve and they disappear on their own. Only endometriotic cysts would persist. Actually, can we ask all investigations like FSH? I am not very sure about FSH, LH, prolactin, etc. I think that you are going overboard with that. In my routine of workup of infertility patients, I hardly ever do FSH, LH. If their menstrual cycle is regular, what is the need of that? What do you want to prove that? And although in cases of polycystic ovaries, for assessment of and technical diagnosis, you need to do FSH and LH, but practically I rely quite heavily on the phenotype of the patient, on general appearance, what it is like, and on ultrasound, the polycystic ovarian appearance, because hormonal evidence may not be very necessary in that. Why do we LH is in PCOS is any?
Why do we do LH in PCOS?
Well, in LH, the LH usually is raised if you do FSH LH. Remember, you do it in the first 3 days of the menstrual cycle when she starts to menstruate, preferably on the 2nd day. And the LH is higher in this because LH, if have I given that lecture of PCOD or not?
No.
No. If you look at the generation of FSH and LH, you see there is a problem in LH pulsatility from the anterior pituitary, because of which there is that LH generator is not working properly, because of which there is excessive production of LH compared to FSH, and that affects the ovarian stromal cells, to produce more of androgens. So LH is raised in these patients who have polycystic ovaries. I'll give you that lecture of polycystic ovaries in one of these coming days. So LH is, from that point of view, important. In patients with irregular cycle, when we do serum progesterone to confirm ovulation. You see, serum progesterone is rather an indirect way and not always reliable in the sense that it's dependent upon lab, etc. And it may vary, not necessarily 21 days. That cycle may be a little out of sync, etc. But if you have vaginal ultrasound is now so common, and if you are a practicing gynecologist, one would expect you to have a vaginal probe as well. And if you do that on day 12 to 14, that is my routine of doing an ultrasound after ovulation induction or otherwise in a natural cycle as well to assess the ovulation status or the development of follicle. You do an ultrasound day 12, 13, or 14. And you would see if there is, it correlates with endometrium, say 7, 8, or 9 millimeters, and a follicle of about 14 to 18 millimeter. At that time, you can track it, you can repeat the ultrasound, and you will see that on day 18, 19, if you continue to do that, that follicle has disappeared, which would mean that ovulation has taken place. And if the facility for Doppler is there, then one can see that increased vascularity, etc. After ovulation as well. The collapsed follicle would give its typical appearance. So I find ultrasound to be a much more convenient and readily available method of assessment of ovulation. I have never prescribed serum progesterone. Although to complete the list, it is there, but with vaginal ultrasound, it has gone overboard, and vaginal ultrasound is available for last more than 30 years. For ovulation, what best we do on regular cycle? Well, first, I think it will be worthwhile in a case of regular menstrual cycle to do vaginal ultrasound in a natural cycle to see what the ovaries are like, so that you know that the ovaries are there, the antral follicular count, and then a developing follicle. But to enhance chances or statistically increase the chances of pregnancy with instead of 1, 2, or 3 follicles, you do ovulation induction, and my preference generally is for clomiphene citrate. You can do that for PCO or non-PCO women. Although it was at some time propagated that for PCO patients you give aromatase inhibitors. Aromatase inhibitors have the advantage of preventing ovarian hyperstimulation syndrome because there is a limited number of follicles which are developed through aromatase inhibitors like letrozole. But 2018 guidelines of ASHRAE, they say that you can continue with clomiphene citrate. So clomiphene citrate is all right. For ovulation with regular cycle, examiner gives only these characteristics and asks what you find
of that question
on laparoscopy for scanty periods. For scanty periods. Well, on
PCO, basically the examiner wanted to talk about PCO.
Possibly, yes. Possibly, yes.
Infrequent
Actually, scanty periods means, you see, scanty periods means hypomenorrhea. Is that what it is? That the cycle is regular, but the amount of blood loss is small. Because oligomenorrhea is when the cycle is prolonged. And in PCO, it usually is longish cycle. Scanty periods, from scanty periods, I would understand the amount of blood which is less. But it does not really mean, I often quote a sentence from Jeffcott's old edition, that it does not matter whether a woman bleeds for a week, half a day, or half an hour. It does not really matter. Because even with so much of advances, we are not as yet sure what is the optimum endometrial thickness for even IVF for embryo transfer? Is it 6 millimeters? Is it 9 millimeters or 10 millimeters? Although, if there is a good number of follicles which are developing, I would understand that 10 to 12 millimeter is a good endometrium. But even 7 millimeter endometrium is something on which embryo transfer can be carried out, which means that it is acceptable to have a 7 millimeter endometrium. So if you are talking of scanty periods, which means that reduced amount of blood loss, it does not really matter so far as fertility is concerned, until and unless the patient is having intrauterine synecdoche, which are the cause of secondary periods. And for that, I said that you need to do hysteroscopy to assess the inside of the uterine cavity.
LH का आंसर भी कर दे because मैं
LH का आंसर मैं कर चुका हूँ. For diagnosis of PCO, we follow criteria which include LH and exam. What strong justification? Well, if you do the second day FSH LH, the typical PCO findings would be that LH value would be double that of FSH, and that is, as I already explained, is the problem with hypothalamic pituitary connection, which makes the generation. I'll show you a picture. I'll show you a slide of that. How it does. वो मैं दिखा देता हूँ आप लोगों को. अभी उतनी देर तक आप मैडम जरा नहीं और कुछ बात चीज बतानी है. Honestly, we need LH values.
That's a very good question. So yeah, we want to do IVF, but the patient is not affording. So what are you going to do then?
आजकल अगर जब आप IVF की बात करो तो लो कॉस्ट IVF के बारे में पता होना चाहिए कि वो क्या चीज है. पैकेजेस नहीं, लो कॉस्ट IVF का मतलब है कि आप उसमें HMG नहीं देते हो या FSH नहीं देते हो, आप उसको क्लोमिफेन सिट्रेट से करते हो. That is again is not cheap, but that is some that's a
but that reduces the cost.
That substantially reduces the cost.
So if they can't afford an IVF, what will you do then? क्योंकि जो तुम IUI बार-बार कह रही हो, for IUI you need patent tubes and healthy tubes. If there are no healthy tubes, then you cannot go for IUI. तो देखो सही जवाब S खान adoption. Because if the patient can't afford it, and then the only choice left is adoption. आप लोग कोई क्वेश्चन पूछना चाहो जो पीछे बैठे हैं? Thank you. Any questions? Anything you want to ask? लड़कियां पढ़ते नहीं हैं, इसको कोई सवाल नहीं. बस स्पेस के चक्कर में थी. किस चीज के चक्कर में थी? No questions from your side? Chalo. So let's assume that this patient was married for 12 years, but she does not have a history of tuberculosis. और पेशेंट का BMI 29 है. अब क्या करोगे? मैडम?
Weight loss, exercise, diet.
जब वो सुनने वाले बेचारे तड़प रहे.
Weight loss, dietary counseling, exercise, weight loss.
No, you would still want to find the cause.
Right.
So you would still want to find a cause because the history of tuberculosis and the presence of one blocked tube suggested to you a tubal factor, right? So because it suggested to you a tubal factor, you worked on that tuberculosis line और तुमने उस पे IVF पे पहुंच गई वगैरह वगैरह. लेकिन if the same patient presents to you with 12 years of infertility, no history of tuberculosis, and she has got a high BMI, what are you going to do then? So I don't want you to jump onto weight loss, but I would like you to say कि तुम्हें उसकी इन्वेस्टिगेशन करानी और भी इम्पोर्टेंट होगी. शादी को 12 साल हो गए. 12 साल में प्रेगनेंसी क्यों नहीं हुई? And as I said, there are 4 main causes, important causes of infertility, which are your tubal factors, which are PCO, endometriosis, and male factor. So you should say that I'm going to review these things. And for reviewing these 3 things, you actually need a day 12 ultrasound. I would also like to do an AMH क्योंकि 12 साल हो गए.
30 years.
तो क्या है? AMH लो लिया था 30 years पे. I would do an AMH. I would do the day 12 ultrasound to look at the ovulation status and do a entered follicle account. Entered follicle account will do 30 years के बाद चलती है, but हम करते हैं. And I would also do a diagnostic laparoscopy plus hysteroscopy and a husband semen analysis. Once I've done all that, then I will try to look at what are the causes and what are the suggested causes. So according to the cause, then I'm going to treat the patient and I will do a detailed counseling. Regarding prolactin and TSH, we normally do it as a part of investigation, but they are not very focused or sensitive tests. So then once you know what is the cause, then you will make a treatment plan according to the cause. However, because she's married for 12 years, although she's only 30, but she has taken multiple ovulation induction cycles, so you will make a treatment plan for her. And you will tell her that according to your investigation, this is the possible cause, and this is the treatment plan, and this is for how many years do you want to do that treatment, and then you want to go on an IVF. Because ultimately, at the pregnancy neoria, and even if everything is normal, and you will also talk about lifestyle modification, you will talk about weight reduction, because when I told you that the BMI is high, I was leading you on to PCO. So there may or may not be PCO because the cycle is regular. So what I will say is that I will do lifestyle modification. I will, whatever cause that I have diagnosed, I'm going to manage according to that. Then once I have treated that, then I will do, क्योंकि मैं normally अगर PCO होता है और 20 PCO है तो मैं उनका जब तक weight reduction नहीं होती, ovulation induction पे नहीं जाती. So once you have achieved the BMI that you wanted to achieve, then you do ovulation induction, and you can actually shorten the route by going for an IUI rather than depending only on natural cycles. And sometimes you can also see कि वो follicle rupture भी होता है कि नहीं होता, क्योंकि कईयों में ये issue होता है, कईयों में issue होता है of endometrial thickness. So if endometrial thickness is not enough, despite whatever you are doing, she is not going to get pregnant. So for that, you are supposed to give some hormonal treatment to increase the endometrial thickness. So ये वाली बातें जो है ये करनी जरूरी है, लेकिन 12 साल वाले को आपको टाइमलाइन देनी चाहिए, उससे डिस्कस करके उसकी अफोर्डेबिलिटी देख के उसकी विलिंगनेस देख के. अगर 12 साल वाले को मैं स्ट्रेट कहूँ ना 12 साल हो गए IVF करा लो, तो there is good probability that they will say let's go for an IVF, right? So you have to see what is their limit, what is their financial status, how far are they willing to go, because you know taking treatment for 12 years was also not very easy. It was also a costly treatment, right? जब हम कहते हैं वो IVF अफोर्ड नहीं कर सकते, तो 12 साल से गोलियां खाए जा रहे हैं, वो भी फ्री तो नहीं. So you have to think about the financial optics, but at the same time you have to think कि हम उन्हें कितने अरसे तक ट्रीटमेंट पे रखने को तैयार हैं before saying कि let's go for IVF, even if everything is normal. Normal या weight reduction कराएंगे, because it is believed that if you do 20% weight reduction, तो ovulation improve हो जाती है, right? Not only in terms of ovulation, but also in terms of quality of egg, right?
वो टेस्ट करते हैं हम टेस्ट गूगल मीट पे.
आप कैसे summarize करते हैं केस जैसे तो?
So if you give me the history, I'll tell you how would have I summarized. I would have said Mrs. Swendodi, I would have said Mrs. KF, 30 years of age, primary infertility 12 years.
So just we have to state.
Straight and short.
Okay.
Primary infertility 12 years. Primary infertility 12 years. Semen analysis normal. Hysteroscopy 2013. और semen analysis की भी डेट बतानी चाहिए, because and husband history भी important है, because he could have diabetes or something. बतानी चाहिए, ठीक है. So semen analysis is normal. Somebody में ये बताओगी semen analysis is normal. Hysteroscopy right tube blocked, and multiple cycles of ovulation induction, and other investigations are not visible. Now presented for treatment. No positive finding on pelvic examination. That's it. As short as possible.
I want to ask one thing that estimates the primary infertility. She has no discharge or anything. Do we do a speculative examination and a pelvic vaginal examination?
Absolutely yes. You must always do it.
Always for a gynecological.
For every gynecological patient, a complete physical examination is mandatory.
Right.
You must do it. उसके कोई बचने का तरीका नहीं है. Even if everything is normal.
अच्छा जी, ये है उसका जो LH और FSH का माइक ऑन करो जी.
Follicle count. Yes. The answer is yes.
अच्छा
Hysteroscopy should be, मैं एक बस सवाल का जवाब दे दूं. Hysteroscopy should be done as a part of investigation of every patient of infertility.
Okay. Okay. Now, this is the hypothalamic pituitary dysregulation which happens in polycystic ovaries. And here you will have to concentrate on this solid line and this dotted line. And this is normal. This pulsatility of LH. This is regulated by gonadotrophin releasing hormones from hypothalamus. And in this, granulosa cells get stimulated normally. And the ovary goes through its normal steroidogenesis, in which case estrone is converted to estradiol here. But this, if you look at here, this is the genesis of right from here, from cholesterol, it's pregnenolol, or from pregnenolone to progesterone, 17-hydroxylase converts it into 17-hydroxyprogesterone. And then that is converted into androstenedione, which is, of course, an androgen, and then testosterone. Androstenedione gets converted into estrogens through aromatase. And letrozole, what it does is that it, I'm digressing a little bit, aromatase inhibitors reduce the formation of estrone. And that's a negative feedback to the pituitary to secrete more of FSH. That is the mechanism how letrozole stimulates increased FSH. But
Mic
that is
off,
something by default.
Somebody is saying mic is off.
वो माइक नहीं आ रहा.
वो देखिए वो mic off आ रहा है.
एक मिनट. नहीं, मेरा माइक तो ऑन है.
Can you hear us?
ठीक है, ठीक है.
सर आपकी आवाज क्लियर है.
No, no. Hello.
जी
सर आ रही है.
What happens in PCO is that there is a issue with this generation of the because of GnRH dysregulation, and there is excessive production of LH that results reduced stimulation of granulosa cells and increased stimulation of
सर आप अपना ना माइक म्यूट करके ना अनम्यूट करें, डिस्टॉर्शन आ रही है, मे बी शायद मोबाइल की वजह से.
It's underway within theca cells. एक तो ये माइक म्यूट कर दूं अपना. What I'll do is that I'll put this slide on to the WhatsApp group, and then you can
take a picture.
Yeah, it's a little hazy over here because the picture is quite clear, and that will be disseminated to you, and you can understand. It's quite easy. It looks maybe looks a little complicated, but it's easy. Here, if you look at the top, gonadotrophin releasing hormone is responsible for production of FSH and LH. Normally, there is increase in FSH and LH is rather suppressed because LH is produced only at the peak in the mid-cycle. And theca cells go through their cycle of converting cholesterol into
वॉइस आ रही
Again distortion. अब मैं चुप हो गया हूं तो ठीक हो गई. ऑन कर लूं? ये मेरा तो ऑन है स्पीकर.
जी सर ऑन है. मुझे लगता है इंटरनेट की स्पीड का कोई इशू आ रहा है.
अच्छा चलें अब ठीक है. अब आवाज आ रही है?
जी सर आ रही है, आ रही है.
सर अभी सही है।
ओके ओके ठीक है. चलिए जी. ये खैर ये सारी गायब हो. ये मैं ये वाली स्लाइड दे दूंगा, तुम लोग लगा लेना ये. ठीक है. हाँ हाँ जी. अभी अब मेरा ख्याल है बार बार रिपीट करने के बजाय आई विल पुट दिस स्लाइड अप एंड इफ यू जस्ट कंसंट्रेट ऑन दैट सॉलिड लाइन एंड द डॉटेड लाइन you will understand that solid line means emphasis and dotted line means that that component is less effective or less active, and it's quite self-explanatory. I think it's quite simple, and I'm sure that you will understand with this. So that takes care of this LH and FSH thing. This we'll take up in detail in another lecture about about polycystic ovaries. नहीं वो देख लेंगे. ठीक है. मैं किस चीज का
सब कह रहे हैं मैं किस चीज का एक्सपर्ट नहीं.
हाँ हिस्टेरोस्कोपी का नहीं हूँ मैं.
उसे इनको बुला लेंगे.
वैसे मैंने आज तुम्हारे लिए
अच्छा इस केस को क्लोज कर दें.
हाँ ये केस को क्लोज कर दें.
तुम्हारे साथ कोई ज्यादती नहीं.
बच्चे तुम्हारे लिए मैंने वैसे ना तैयार किया हुआ था. अगर तुम ना करते ना तो आज मैंने ये लेक्चर देना था.
कौन सा देना था? मैंने भी देना था.
आपने ऐसा कहा था मुझे, अगर मुझे कह देते कि मैं कर दूं.
मैंने आज अच्छा ये मैं एक मिनट ये नहीं है. ये जाहिर है रुबीना भी इसमें अपने वर्ड्स ऑफ विजडम डाल देगी. हम बंद करने वाले हैं ये. I had planned to.
Why don't you talk about half an hour on something? या इस पे कर लें या
नहीं अभी तो टाइम खत्म हो गया. अब नहीं है. बट मैं ये कहना ये चाह रहा था क्योंकि हमारा प्रोग्राम कुछ टॉपसी टर्वी हो गया था. एंड आई हैड आस्क्ड सना टू प्रिपेयर अ केस.
जुलाई में ना मैं आपको इसका पूरा प्रोग्राम बना के दूंगी और
एंड मेक हर केस प्रेजेंटेशन which I must admire that she did. She was on duty last night as well.
सर आप बताएं आपने पहले इसको कितना.
अच्छा मैं अभी बात दूसरे सुन रहे हैं ना इसलिए मैं कह रहा हूँ उसको छोड़ दो अभी. हाँ अभी है तो वो उसके लिए हमने ये किया था. But when I was looking at this presentation about operative delivery and assisted vaginal birth, this is pretty long. I'll have to cut it short because it comprises of 72 slides. But what it requires is that you, before you embark upon operative or assisted vaginal delivery, you need to be quite comfortable with normal vaginal delivery. And that normal vaginal delivery is something that you should master yourself. And then familiarize yourself with the various modalities of assisted vaginal deliveries which you can take up. So we'll talk about operative delivery or assisted vaginal births at some later stage. Thank you very much. If there are any questions, we'll take that.
Sir, I have one question. Sir, we know that I'm again asking for the PCOS, is that we know that we have that rotatum criteria to diagnose that. But in exam, why do we need to ask about FSH and LH? Because it's just support our diagnosis. Otherwise, तो हम लोग rotatum ही follow करते हैं. Then what's the point of asking?
Actually, no. You see, if you take overall picture, the diagnostic criteria, as you said, are 2003 Rotterdam criteria, and any two of those three features, which is the metabolic appearance or metabolic syndrome appearance of the patient, or the hormonal thing, or the ultrasound thing, those are there. if you look at the hormonal upsets which can happen or which are characteristics of polycystic ovaries, disturbed FSH-LH ratio is part of that. And therefore, if it is asked, why is it there? Because if you look at it, it is one of the mechanisms, although we do not understand completely even now, the mechanism or pathophysiology of polycystic ovaries. But one of the modalities through which the effects are manifested are the FSH and LH levels. How they affect, how they, as that diagram explains, that because of that disturbed ratio of FSH-LH or because of higher concentrations of LH right from the beginning of the cycle, the hormonal milieu of or hormonal production of the ovaries is disturbed. And that the net effect is that there is slight increase in androgens. And that is most likely and most often responsible for many of the upsets.
Can I add something? You know, it is not only FSH-LH you're doing only for polycystic ovaries. We were talking about a case of infertility, not about polycystic ovaries. So there might be that the FSH is high, and that is why there's an issue with ovulation. So I think FSH and LH are two very relevant and pertinent investigations to be done on cycle day 2 for any case who has got infertility. So you might keep on treating her and you find her FSH is 14 then. So then you need to know, that is why as a baseline FSH-LH should be done.
वो ये पूछ रहे थे कि जी पीसीओ में फिर हालांकि रोटरडैम क्राइटेरिया होता है तो फिर एफएसएच-एलएच क्यों पूछते हैं एग्जामिनर, वो पता होना चाहिए वैसे उस तरह से.
हाँ, लेकिन मैं वैसे बता रही हूँ कि FSH-LH is not important only from PCO perspective. It is also important from other perspective.
Okay ji, okay, thank you very much everyone. Good to have you all here and hope you have but it's good interactive that we get to hear from them and respond to them.
I think we should add Dr. Yusuf Latif. He's also there. Would he like to add anything?